Welcome everybody. My name is Paul Turner. I'm a holistic osteopath practicing in Australia, and I thought I'd share with you some information which I think is very, very important in terms of helping modern day education, research and practice. Now it's a long video, but it's a vitally important one, so perhaps if it's a bit too much to watch in one sitting, just watch it in small little bits. But if you bear with it, I think you'll find it's very interesting. So I'm going to first of all discuss a lot of my own clinical experience and reasoning about this topic, and then at the end I'm going to talk about all the different forms of evidence I'm using to back up this discussion. So I originally wrote an article on this, and it's a very lengthy article because in order to see what's actually missing in some ways from the education to make it more holistic and rounded out, it takes a little bit of preparation work and discussion. We have to sort of look at what's going on, explore it from many different angles, and you'll start to see, hopefully by the time we get towards the end of the discussion, why I'm posing this question and why we need to do something about it to improve our education and practice. So the question I'm posing to you is this: are we losing our holistic identity, in our case, true holistic osteopathy, but it can apply to any therapy, to the overemphasis on reductionist or condition symptom focused evidence-based medicine? Now, although I'm coming at this from an osteopathic perspective, I have observed this to be true with any holistic therapy. So if you're not an osteopath, have a think about what I'm about to say, see if it relates to your therapy, and then make your own mind up whether you think this is important information and whether there is indeed something missing we can add back in order to improve medicine in general in every field. So as an osteopath who applies osteopathic principles in practice and who looks more at the bigger picture, I felt compelled to voice some serious concerns regarding the emphasis of modern day education, research and practice. I don't mean any disrespect to anyone in pointing out these concerns, but I do feel it's necessary to bring them to your awareness if they're not already in your awareness. So please take this discussion very seriously, because I, for one, do not want to see osteopathy or any holistic therapy die a gradual death through omission without anyone being the wiser that this is even occurring, when something can quite easily be done to bring back a balanced osteopathic or a balanced holistic perspective back. So what prompted me to write the article and then do this video is I noticed a while back, relating to correspondence from my own association, about the concept of providing more CPD courses to practitioners with evidence-based practice behind them. So this got me thinking. And to be honest, although this is a healthy thing in many respects, I can't help but feel a little saddened that everything nowadays is so focused upon what I would call external evidence-based medicine that it often distracts from the importance of developing the ability to use our human instruments, our own instruments, our own senses, to uncover and trust what I call internal or primary evidence from the tissues of the whole person, from our holistic postural assessment. Now, I know in evidence-based medicine that they have their own little category of what they consider reliable evidence, but the evidence I'm talking about here is the real evidence from the tissues of the body, from direct assessment. Okay, so it's stuff that we can see, we can feel, we can observe. Okay, and if we learn to develop our senses to pick up this information, then it provides all the answers we need to make a rational treatment and management plan. So we're so focused upon external research, thinking it's all forward progress, that we are at real risk of missing the point and value of what it is we can potentially do well, and thus risk losing osteopathy in the osteopath, or the holism in the practitioner, so to speak. And this often occurs without us even realizing that we've done this. It seems to me, in relation to osteopathic assessment and treatment, from observing the content of people's LinkedIn and Facebook comments, the emphasis of in the CPD courses, workshops, and the modern biomedical education and practice, that we are limiting in many ways our professional potential and value rather than expanding upon it. My observation, and also others, shows less understanding and application of the osteopathic principles in practice nowadays rather than more. So I will give examples of this later, but for now, I feel this is likely linked to the distraction of our attention by an overemphasis on things like pain, tissues causing symptoms, conditions causing symptoms, and upon the more theoretical and technical elements of biomedical knowledge or of parts, rather than a holistic integrative elements and that of developing ourselves as instruments of perception to be able to reliably pick up clues from the body tissues, and thus the more practical applications of holistic principles in practice. You've got to remember that we're an instrument, we've got to develop the instrument to pick up the information. We can push all this knowledge into our heads, but unless we can actually use our instruments to pick up the information from the tissues, that knowledge remains intellectual and purely theoretical and hypothetical. It seems to me that through lack of emphasis on the more holistic elements of practice, for example, that which gives understanding and context about how everything fits together, that the osteopathy or the holism in the osteopath or practitioner is gradually getting killed out rather than being practiced, growing, and thriving. We are thus only doing a fraction of what we are truly capable of because all the things which make us better at what we do, such as developing our practical understanding of our philosophy, our principles, our holistic assessment skills, are not perhaps emphasized as much as they should be in our education, our research, and our practice, and thus tend to fade into the background and simply cease to be. If it's not in your consciousness and other things are put into the consciousness in their place, these sort of things can often just fade into the background from lack of attention. And before you know it, we've reduced the whole concept of what holism is to a part of holism, and then another part, a smaller part, a smaller part, and so on. So the following discussion discusses concerns about modern day over-reliance on what I call secondary evidence from evidence-based medicine to the detriment of observing primary evidence from a holistic osteopathic examination of the tissues of the whole person. Before I go on, I'm just going to show you a chart of what I have termed the types of evidence from a practical perspective, not an evidence-based perspective in terms of external, but internal, what we're feeling and sensing with our own being. So this is a summary of the types of evidence. I'll talk about this first, and I'm going to refer back to this diagram over and over and over in the following discussion and when I give examples in real life. Okay? Are we losing our identity by being over-distracted by evidence-based medicine and a pain-focused approach? Okay? So look at the two types of evidence. On the left, you'll notice here I've put 1, primary evidence from the tissues of the whole person, which is what I would call internal research. This is our own personal internal research we do every day in clinical practice. This is what we find from our assessment process, and itself is identified from, let's say, 2 types of assessment processes. So the 2 types of assessment processes are, the first type is what I'm calling 1A, which is our general holistic, in our case, osteopathic assessment or screening process. Now, the goal of this general holistic assessment process is to identify primary areas which have all 3 of what I call A, R, and T, which is called the what else and the whole being contributing, causing, setting up the tissues causing symptoms, or otherwise slowing recovery by interfering with the body's self-healing mechanisms. Now, I talk about all 3 of ART. I've written about that in another little article, and we'll put a link at the end to that. But you can sort of prove, well, very briefly, that I've got a little note at the bottom here, right, that ART refers to traditionally asymmetry, range / quality of motion abnormality, and tissue texture changes. It used to be just range of motion abnormality, but everyone focuses on the range and not so much on the quality. So I've actually looked at it in quality. Quality is actually reflecting function, okay? Technically, range tells us something that is limited in terms of something might have a limited range, but quality tells you if it's dysfunctional or not. So that gets us back to this definition of health and disease, which I've also added a link to another little video or article on that. So quality actually refers to function and the relationship between any two elements of the body, whereas range just tells you something's limited. So for example, if I have you standing next to me and I push you down towards the ground, so I limit your range, your quality within that range is still okay. You just can't go any further because I am blocking you. Okay, you might have the symptoms, but I'm causing you to have a limited range. So the relationship between me and you is dysfunctional. So range doesn't mean you've got the problem. I'm the one who's causing the problem in this case. Quality will tell you where the actual problem is. That's something I can go into a bit at a later date. So a structure may be asymmetrical, altered in its range, and have some difference in texture, but still technically be functioning okay, even if symptomatic and tender, which could be a clue to its adaptive nature and effect only. So it makes a little bit of sense when you talk about primary and secondary dysfunctions in the body, because if you have, say, a real problem, okay, let's say you have a joint like the sacroiliac joint, and you have a problem there, it'll be dysfunctional, have a poor quality of movement, but it should have, so therefore it'll have altered quality of movement. It'll probably be asymmetrical because the joint is either squashed together, which lessens its range, or it's pulled apart, which is stretching the tissue. So it's either compressed or it's stretched. So that'll create asymmetry and also altered texture if you're feeling it. Okay, and it may be painful because it's compressed or stretched, irritating pain-sensitive structures. So you could argue that when you have a true dysfunction, it has all three of those components, A, R, and T. If it's a secondary problem, you might say we take the same sacroiliac joint. It might be compromised in its positioning because of a problem somewhere else. Okay, so you could have the sacroiliac joint, like one of them stretched, which is stretching the ligament, creating altered texture, or it could be compressed, jamming it up, which will create altered texture, and it will be symmetrical, but when you actually check its quality of movement, it might be okay within that range, telling you that it's perhaps adaptive. So you could argue that for a true dysfunction to be present, all three of ART must be present. If you only have one or two of those, then what happens is it could be a clue that that structure that's symptomatic or painful could be adaptive to some issue somewhere else, just like in my example of me pushing you down towards the floor and limiting your range. Okay, so the question is, where is the real problem in the body? And this is what our general holistic assessment is determining. It's not determining what's causing the symptoms, it's determining what else is happening in the whole person, what other relationship imbalances there are that are setting up the tissues causing symptoms, or otherwise slowing their recovery by interfering with the natural body's self-healing mechanisms. So I hope I've explained that okay. So the note here is this provides the context for our regional assessment 1B. It tells us what we can actually treat and is often safe and supportive to the overall recovery. I'll give an example here. For example, someone might have sprained a ligament or strained a muscle in, say, the calf or ankle or something like that. There may be inflammation and swelling and a lot of pain and tenderness. You may not be able to treat the tissues causing symptoms immediately except with first aid, rest and ice and so forth, but there may be issues in the pelvis or somewhere else in the body that's interfering the blood supply in or the drainage of waste products and whatnot out. So your assessment might determine there's problems in the pelvis or the rib cage or in any of the pathways which would be interfering in that tissue's ability to get nutrients and to support the healing process or to remove waste. So that would be safe. The body will show you that. So you might be able to do your first aid on the calf, but you can treat other things in the system which may support optimal healing and recovery. So we're not doing the healing. The body will do the healing itself, provided the environment is balanced and safe, and it'll heal in a more optimal time frame. This is why it's so important to do this general assessment and to get clues from it. Okay, but however, this element of assessment does not seem, at least in my observation and experience and teaching experience, to be emphasised or developed and reinforced to an adequate level in current education, research and practice. And I will give examples of this later. Now, hopefully this will change over time, or it is changing already in some situations, but it's over the years I've been in practice, there's still so much evidence indicating this is not yet done as well as it could be. So this gets us onto the second part, 1B. This is our regional and local assessment process for the tissues and conditions causing symptoms. Okay, so this actually is done reasonably well from what I've determined or observed in my experience by most people, if they're interested in actually assessing the body, not just doing a treatment without fully assessing. So this is based on symptoms and a more biomedical or condition-oriented education, and is more likely linked to this concept of TART, with the extra T being tenderness, which relates to what the patient feels and is not a true sign or of ART, which is what we feel. So I'm making a little distinction here. In the modern education, there's this concept of TART. It used to be art and now it's TART. The reason I feel that's become like that is because art used to be used by holistic practitioners to determine what else was going on in the body. As we've lost our identity and we've been increasingly focused onto the symptom area, the tissues or condition causing symptoms, the modern day education and practitioners have added TART, because tenderness is what a lot of people are going on pain, okay, or tenderness. Now tenderness, I'll make a note here, really important, is what the patient feels to our touch, not what we feel, okay? We'll feel asymmetry, we will feel altered texture, and we'll feel quality of movement abnormality, but the patient will feel T. So it's, if you think about it, it's taking our emphasis from what we feel to what the patient feels. And if we keep following that path, we end up treating what the patient wants us to treat based on their wants and not upon the true tissue needs, okay, which is art. So we've prostituted art and turned it into TART, in my professional opinion. And that's the reason why. TART could arguably be used to identify in the painful area the dysfunctions that are present in that area, contributing to the symptoms. So that could be a way to use it, but it shouldn't be used to determine what else is happening elsewhere in the body, because those areas may be asymptomatic. In the same way that I would have no problems holding you down as much as you might be uncomfortable with me holding you down, okay, because your range is limited and you're cramped and compressed, but you're going to feel more discomfort than I am, okay? The same way, if I push you over to the side and you're sort of leaning to the left or the right, after a while your tissues are going to get fatigued and painful because you can't stand there all day in a crooked position. The muscles are going to tighten up and the tissues are going to be asymmetrical, but they're actually doing their job to maintain your posture in a crooked position. So that's an example, okay? Whereas holding you in an imbalanced position is relatively easy for me, and I won't be symptomatic. So there's your argument of TART versus art. So in a way, you've got to restore the healthy relationships, because those muscles and joints and tissues that are doing their job to maintain your posture in an imbalanced position will eventually get fatigued to the point they do get dysfunctional, in which case they might need some treatment to get them functional again, but that's only getting them coping, okay? Coping with my stress that I'm imposing upon you. To deal with the real cause, you've got to deal with the relationship again between the person that's pushing you over and you, okay, to get the balance. If you take the pressure off, the weight bearing will be even, the load comes off the muscles and tissues, and therefore the symptoms will start to decrease, because there's no reason for the tissues to be holding asymmetry and tension anymore. Okay, it's sort of that simple. So there's your little discussion on the general holistic assessment versus the regional assessment process, and there's your explanation of the benefits or the advantages and disadvantages of art and TART, and you can start to order it into its correct perspective, so it helps to enhance your assessment, not distract from your assessment. So that gets us onto the second part of this diagram, which is what I'm calling secondary evidence, which is evidence basically from a secondary source, someone outside of yourself. okay, from external documented research. So everyone's on about you have to be research this and you have to research that, but that is someone else's assessment. If that research itself is meant to be accurate, theoretically they would have to do a good general and regional assessment in their own practice and then do external research upon it. So even external research, if you trace it back, must be based on a good assessment process. If it isn't, if it's only, say, doing regional and missing the general, then the evidence will be only evidence of a regional assessment process at best. And this is what I'm going to talk about. So if you think about it, secondary evidence does not tell us what actually to do, what to treat, but it does provide background information about what other people are up to in terms of current trends in exploration, thinking, and capability. For example, or i.e., researched information that's known to date out of the collective unknown. To me, true science is exploring the unknown to make it known and render it more sort of user-friendly for the public. Okay, it's not meant to just rehash the same old, only research your belief and then try to propagate that. Okay, it's always to try and understand more about the whole picture, not to limit the whole picture. So this type of evidence rarely, I feel, adequately explores category 1A, the general holistic elements, but does often provide detail in relation to the category 1B in terms of regional and local biomedical investigation of tissues or conditions causing symptoms. Therefore, it's helpful usually only in a regional reductionist and symptomatic way, but consider this, without the context of the whole system, it may at times be distracting or even misleading. From one perspective, it's providing evidence that the symptomatic viewpoint on its own is actually not that effective and that something is as yet missing, perhaps the 1A category, in terms of chronic illness, especially that which is needed in the future research for a more complete picture to emerge. For example, research on treatment techniques and their effectiveness are often performed from a reductionist symptomatic viewpoint, which is 1B, and limited in its results because the perspective of the whole, 1A, which provide context, is not usually included. Okay, this is what we're going to explore, so bear with me. We're going to give you plenty of things to think about, and we'll move on now to our discussion. So I sort of just presented maybe a different category of evidence for you, or maybe it's something that makes a lot of common sense to you. Now we're going to explore that a little bit further in terms of a common sense, rational discussion. So let me just say one thing. From the outset, let me assure you that I have no issues or objections to the practice and use of evidence-based medicine, especially when it's carried out by practitioners who both know and understand how to listen to the body and how to use correct methodology with which to test and measure their hypothesis. In the hands of those who know, it shares valuable resources with other people. The best research seems to me to be performed by those practitioners who have spent a lifetime observing the body and its relationships, its phenomena, and its remedies to support its recovery and so on, in its natural environment. And they simply conduct external research to give evidence of this and share their insights with the world so everyone can benefit, hopefully in a shorter time frame without perhaps having to go through all the issues and mistakes along the way. Okay, so it can help in terms of an educational direction. This, we may say, is the ideal of good research. What I do have an issue with, however, is the fact that in today's education and practice, evidence-based medicine is taken as gospel and is regarded as something upon which we must rely, even when it completely contradicts real truth, common sense, clinical experience, and pure reason. It is getting taught as if it is the be-all and end-all of modern-day practice, and if we don't base our practice and education upon evidence-based medicine, then we're doing something wrong. So this is sort of true and false at the same time because you need context to understand this statement. This is a very dangerous assumption, and one which often flies in the face of many of our holistic or osteopathic principles, and even in the face of common sense reasoning, as it will become evident in the following discussion. So I'm going to make a statement here. We don't need research to tell us what to do. we use it to share what we do. It's for sharing educational purposes, okay? Done by those who know to help those who don't perhaps to become aware of it, okay? But the question is then, the other people doing research, do they really know? Do they listen to the whole picture? Or are they just assessing based on a regional symptomatic viewpoint? This will become apparent when we start looking at the evidence I'm presenting later on, okay? And then you can make your own mind up about how you practice and how perhaps you'd like to practice. Would you like to see more of the whole picture and understand how to read the tissues of the body? Or are you happy just treating the area with symptoms? So these are all things we should ask ourselves. Research is not necessarily proving to ourselves as individual practitioners that osteopathic treatment is effective for any particular condition, unless we're perhaps insecure about our own capabilities. If we know what we're doing and we're listening to the body, and we're trusting the self-healing mechanisms, we already know what we do is effective, provided we are assessing and treating problems well. So the key is knowing that we're assessing and treating the bodies and the tissues well. Okay, that gives us confidence in what we do, and because we have context by seeing how everything interrelates, it makes it safe. So we're not going to we're going to treat things that are safe to improve relationships, and that way we're not sort of treading on the toes of we're not treating necessarily red flags, things that are dangerous to treat, because we don't have to treat them. All we have to do is restore balanced relationships. So you can sort of think about it that way. So we know what we're doing if we basically assess and treat well. It gives us confidence, it gives us context, it helps us to know what's safe and what's not safe, so it actually gives us better informed practice. Okay. Then we use the external research to perhaps as a resource to support this internal process. External research is rather providing evidence of this fact to the external world and for those practitioners in any field who perhaps have not considered its content as yet and who want to expand their awareness to include it. So it gives ideas to others to try from those that are, really on the frontier of their own, in their own field, of the leading their own field. How do we know, though, that the practitioners conducting the research completely understand holistic osteopathic principles in practice? Good question. My observation of most research that I've seen seems to indicate that it's primarily biomedical or regional or condition-based rather than holistic. I'd say there's some good research on that stuff, but the holistic, not so sure. When I conducted my own research on holism in osteopathy, and I'll put the link into that research. I made a little video up with 4 parts to it, which I think are really important to watch. I'll put that link at the end. But when I did this research in holism and osteopathy, I wasn't able to find what I would label as true holistic research anywhere. I'm not saying it's not there, I just couldn't find it. Although we may acquire, so think about this, although we may acquire an honours degree, a master's degree, or a PhD, it simply means that we understand the research process itself and are reasonably proficient in it. A similar proficiency is not necessarily guaranteed in terms of holistic integrated understanding of osteopathic principles in practice on both a theoretical and a practical level, or that we're even treating patients on a holistic level. Okay, so if you think about it, when we do our research training, a lot of it's on learning how to research, okay? And we just pick a topic and we apply the concepts of good scientific principle to that topic. But that doesn't necessarily mean we understand the field that we're exploring. We might be just beginning and not be sure of it at all, okay? So many times the researchers choose a topic that they're interested in, obviously, in either proving or disproving, and may at times be guessing a testing hypothesis which they know of, but have no real experience in clinical practice or real life. Some researchers investigate topics that they already know and they know that work, and thus provide supporting evidence and reinforcement of things we already know or already known. Some don't research or demonstrate anything clinically significant at all, and there's probably many reasons for that. And others can even mislead readers or viewers into believing something is true which is actually inaccurate and false. For example, it may have been research based on biased, non-understanding or limiting viewpoint, or using methodology itself, which is inadequate to measure the phenomena explored. So, like I said before, you have to develop the instrument to measure the phenomena. If the instrument isn't there, then the research is flawed from the beginning. Another thing that I've often observed is, because it's a part of the education system that students have to do a research component, much research is done by students who have little clinical experience about topics and treatment techniques and principles that they've not built into their experience with wisdom in the crucible of life and practice, and have not developed to a reliable and accurately reproducible level. So you could say that as a student, and I remember like when I was a student, it's like this, we're dabbling in something we haven't fully understood yet. Okay, so it's very different if you're dabbling in something and don't really understand how it works, or don't even know how to apply a technique to the right area. It's just guessing. How effective is that research going to be compared to a practitioner that's had 30, 40 years of real life experience, trusting the tissues, and I might add, getting extremely good results from those treatments, which is your real evidence that the treatments are effective in the quality and the flow and the health and the well-being effects. So, thus, much research can be purely theoretical and likely to be carried out with little awareness of the response of the tissues to the application of techniques. I'm going to repeat that because that's a really important statement. Carried out with little awareness of the response of the tissues to the application of technique. What I'm saying here is a lot of the time we run through an assessment process and we perform the things that we learnt at college, but we don't pay any attention to the response of the tissues because we're so focused on doing something, we forget to listen. Okay, and I'm going to give an example of this later with students that I used to teach, for example, in clinical setting. Yet, this research follows all the processes of good research and at least gives participants evidence in the research process. Also, we need to be mindful that even though the results of some research based upon evidence 1B, in other words, the regional, symptomatic, may show little clinical significance, this doesn't necessarily mean the principles behind a technique's use or the techniques themselves are also insignificant. That's a mistake we often make. It's like throwing the baby out with the bathwater. Okay, that's saying. Just because we don't use it correctly doesn't mean the technique or the principles behind the technique are also useless. And this is something which I've seen happen a lot. The same techniques may actually work more efficiently or effectively when applied to the primary 1A evidence. In other words, once you see the whole picture and you treat the primary ART problems, to restore function, nature can do its work, and then those techniques will work better. And I've seen this happen many, many times in workshop settings. Okay, I used to teach muscle energy, for example, to a class, and I'd walk around, and the students, if you taught it the traditional way with the principles and all that, they will work. But as you walk around the room and you see the students working to apply these techniques on their models, on their people, when you start seeing what's really going on in the whole posture, you realize that they're only using techniques on the wrong part, and that's why it's not effective. So the student then doesn't get any confidence because the technique doesn't work, because they're either not applying it to the right tissue at the right time, and therefore they think they can't do it, which is not true. It means it's not the right area, or they're not often following the principles correctly. What I used to notice basically is if I showed them helped them to find where the real problem was, and then apply the principles of that technique to that primary problem, then their effectiveness would improve, as would their confidence. And not only would they get a local effect, they'd get a global effect, because treating the real problem affects the relationships all the way through the whole body. Treating a secondary problem has a much smaller range of effectiveness. Okay, it may affect the tissues locally, but the tissues will come back into imbalance because the other problems are still there. What else is still there behind the scenes? So I ended up having to teach the principles of how it works, and then teach them how to assess to find the real problems. And then, once they knew where the real problems is, they could then run through their muscle energy techniques and make sure they're applying it to the correct area. rather than just teaching them techniques for every area and then wondering why they're not working. So they ended up learning the principles, and then they could make it up or modify it or apply it to the real tissues in need with greater effectiveness. And that, therefore, improved the quality of the whole experience. So you could say that lack of significance in a study may simply mean we are not addressing the correct tissues and thus have not worked out the whole picture as yet. Remember, research might tell us what to do, but it also might tell us that we don't yet know. Okay, research can thus give us insight into what we're doing well and also what we are not. I'll give some examples of some of these issues later to illustrate this. So you can see, even from this discussion so far, it's to try and dissect this and to get a sense of what's really happening. We have to talk a lot around it. So that's why I'm spending time trying to give you examples and real life experiences. So if this is true and we don't learn to reason and work things out for ourselves via developing our mind and our senses to accurately perceive true primary evidence from our assessment, then we're in very real danger of the blind leading the blind, so to speak. Research is supposed to back up and reinforce our good assessment and treatment principles at best, not substitute for or replace them. Or research gives us ideas for exploration that we have not have thought about on our own. Okay. So, for example, here's some examples. In our profession, imagine a practitioner who has a limited or no practical understanding of osteopathic philosophy and principles in practice, or any holistic principles in practice, and who does not know how to listen to the tissues of the body for actual clues, e.g. the ART concept, about what is happening in any individual case, who then conducts research about what they perceive, or in their mind or interpretation, to be osteopathic treatment, and its effects on, say, certain conditions. Okay, will this not be symptomatic at best? Okay, so in other words, you really have to know what you're doing to conduct research on it, because then you can see, you can make it more effective, basically. Will not the methodology and the results of that sort of approach, no matter how unbiased the person thinks they are, and in following the research methodology guidelines, will it not still be biased and limited by their perception and lack of ability to use diagnostic principles correctly and reliably to read the body holistically, other than perhaps to notice only and treat the tissues causing symptoms? This may be why the results of some research doesn't adequately show the value of holistic principles in practice, whether that's osteopathic or any other profession. I.e., it's not because they are not regionally accurate. They are often regionally accurate, but because the tissues aren't usually, that's not where the real problems are, it's not that effective, okay? But because practitioners may have little idea of how to use them accurately and in a holistic, meaningful, and significant way. That's the thing to think about. If we base our research only on the tissues or conditions causing symptoms, then aren't we technically really only conducting a more biomedical reductionist research on parts with symptoms, not on people with problems? And therefore it's not true holistic research about assessing and treating the person with the problem, and not just the part with the symptoms, i.e. identifying and treating the underlying problem patterns behind the scenes, setting up the tissues and conditions causing symptoms, or otherwise interfering with the self-healing mechanisms, which gets back into that 1A evidence on the chart. Also, research often focuses on and I've heard this many times in studies, the effects of osteopathic treatment on, whatever that may be. We may assume this automatically means that a full holistic osteopathic assessment is performed by whoever conducts the research prior to identify involved tissues in the first place, by someone hopefully experienced enough to receive important clues from this assessment process. If that's the case, how can we be sure that both the holistic and the regional elements in the evidence-based checklist 1A and 1B are both conducted effectively? How can we be sure, even regionally speaking, if the primary tissue components in that region itself are observed and addressed, or if they are secondary adaptive tissues or effects. How can we be sure the practitioners carrying out these assessments are even listening to the tissues in response to the assessments and are picking up the useful information at all? So these are all worth thinking about, these questions. We take it for granted. We assume that those conducting the research are experts in their field. Are they experts in the field? We assume because they're researchers and they've got a PhD, they must be, but that's not actually necessarily the case. It's like the saying, the fruit doesn't lie far from the tree. So I know that this holistic approach was what I was taught when I was studying osteopathy, and yet it doesn't seem to be generally the actual case when it comes to the crunch. And if we have a close look at what many practitioners actually do in practice, okay, and I'll discuss this later. Our strength, or what I believe our strength to be, and what we should be researching, is the ability to find and treat these underlying problem patterns to demonstrate to the world we do have something special and unique to offer. Yet, as you will see, if we look at what is actually happening in general, in the osteopathic world, there is very little indication that this is in fact being done. The indications, I would say, are strong on the biomedical side, but not necessarily on the osteopathic side. This is something which I hope will improve in time. Other than in a few small cases, which I'm sure are out there in the literature, even though I didn't find it as part of my research, we seem in general to be conducting biomedically emphasized reductionist osteopathic research, and that's a bit of a tongue tie in itself, while at the same time claiming that it is true holistic osteopathic research. And very clear observation and reasoning about what is done can often verify this. Okay, so we're claiming one thing in a false name, claiming we're doing holistic research but not actually doing it. Okay, and this is why I'm discussing it in this depth. And we as a profession, meanwhile, don't even realize we're doing this. We have been led astray to a large extent and don't realize it. Why? There could be many reasons for this reductionist overemphasis. One which springs to mind is that perhaps we have an insecurity issue and we're trying to prove to medicine that we're a valuable profession. How? By sacrificing what we're good at to become more like medicine, i.e. reducing our practice to fit a medical practice guidelines. Okay, we seem to look at GPs and medicine as knowing, the leaders in the field of medicine, but it's the same old thing. We try to become like someone else rather than owning our own identity. We end up becoming a puppet rather than an individual owning their power, for example. Now, and I'm not saying that medical practitioners aren't holistic either. Though some of them are, obviously, but they're also falling into this trap as well, in my opinion. So therefore, we reduce our practice to fit the medical practice guidelines, okay? And we think we're making progress, but actually not. Yet in my own research, my own participants said that osteopathy should not be limited to the biomedical, but rather it includes the biomedical, and that if they didn't address what else was going on in the whole system, other than the symptomatic tissues, they would not get good results. So what is this what else, and what does it mean? A topic which I've discussed in my own research, and I've linked that to you in the end. So what is this what else? What does it mean? Is it in fact being researched at all? And if not, how reliable is the research that we are relying upon to educate us about this what else and how to find it and treat it? When we stop and think about it, it makes no sense to reduce what we're doing simply to please another profession that hasn't necessarily worked out the full picture for themselves as yet, particularly in the area of chronic health. I did a lot of research around chronic health, and the chronic health issue is rising despite advances in technology and knowledge. Okay, so that seems to be a contradiction. If we truly understood what was going on in the whole system, then people with chronic health problems would be getting treated more effectively and be getting a reduction in the rise in chronic health issues. Okay, And because of the symptomatic focus and care, you're getting people dealing with effects. The real issues, but this is particularly the case with a chronic health issue, there's usually multiple relationship imbalances in many tissues of the whole person, collectively contributing to that person's manifestation of their symptoms. So this is where this holistic approach is very, very important in terms to improve quality of care for those suffering chronic health issues. So getting back to this sort of losing our identity, instead of owning our power and being good and confident at what we do in dealing with the what else behind the scenes, interfering with the self-healing mechanisms, we may actually be limiting ourselves by focusing solely on conditions and symptoms and doing the same reductionist treatment another way, and therefore actually getting worse. Why? Because we have lost the context of the background picture, which helps us to make sense of why the symptoms are there to begin with, how they came to be, and why perhaps they are not resolving as quickly as they should be. This actually makes us, in the end, worse at what we do, and therefore will increase the insecurity issue because it actually reinforces it. We are now most likely treating symptoms like almost everybody else. The real danger is that we will end up with no respect in the end because we have completely forgotten how to treat a patient properly, and therefore we'll likely make more mistakes and thus providing evidence to everybody else that we do not in fact know what we're doing. Another example, this is something we hear about a lot, the very concept of focusing on what conditions we can help with in advertising guidelines, and that have been researched, and this is obviously, so far, very few relatively speaking. This implies itself a focus on tissues and conditions causing symptoms, and not on the underlying relationship patterns, setting them up or slowing recovery. So, for example, we're told we can't say we can treat this condition or that condition unless it's been backed up with evidence-based medicine. We can say may help with, or we have to be very careful about how what we say when we're teaching people what we can help with. But you've got to remember that we don't treat conditions. If you're treating properly, you're not ever treating conditions. You're only treating the person with the problems, not the condition with the symptom. And in fact, the condition is itself an effect. So if you treat the underlying relationship imbalances that set that up or interfere with the recovery, you're actually supporting the body to heal from whatever it is they may present with. And that's what I believe A.T. Still, the founder of osteopathy, treated. He worked out what was going on within the whole person, and then he made up his techniques to help to restore balanced relationships. And then he got a lot of positive results, as does any good practitioner, with people suffering a wide variety of health issues. Okay, and that was long before they did any evidence-based research on anything. In fact, a lot of the older practitioners that I look up to and I've learnt from, they all do the same thing. They treat the whole person and restore balance, and they get really, really nice results. Okay, a lot of the old, I remember looking at some old research books, in the 1940s and 50s. Some of the practitioners there were describing physiological processes in the body from direct experience, feeling them as if you're literally describing what you're feeling right in front of your eyes. And it wasn't until 20 or 30 years later that the evidence came out to support exactly what they were feeling 20 years earlier. It took an extra few decades for the external evidence to catch up with what people were feeling in their everyday practice. Does that mean they shouldn't be practicing it? No, because if they weren't really exploring the tissues, they would never come up with these things in the first place. So we've got a little bit backwards in many respects. You have to be able to really experience all this to then go and do your research on it, to verify it for the general, to render it verifiable in the external world. Okay, but it all comes back to an ability to see what's really going on. And if you think about it, when you're treating the real evidence in front of you, right before your eyes, you know what's going on. You can feel if it changes, and you can feel if health improves as a consequence of it. So you're actually applying the scientific principles of trying it, testing it, retesting it, and so on as you're going, and you see the results. Not the results, the improvement in tissue health and quality and function gives you evidence that you're on the right track. Okay, so that's the whole point. one of the principles we're taught, so getting back to our discussion, one of the principles we're taught, and obviously taken for granted without much thought, is that we don't treat conditions, we treat people to support the resolution of relationship issues or imbalances within their whole being that are interfering with the body's natural ability to heal itself. We don't do the healing, the tissues, the body does the healing itself. We just help support or catalyze a change, okay? To help the body come into a balanced relationship with its environment so it can heal itself. We treat what is actually present and in need, i.e. the primary tissue evidence. And doesn't the statement that we often hear, find it, fix it, leave it alone, indicate this? When we don't treat what we're told to treat by someone else or a paper about what is in need via secondary evidence or biomedical education without at least verifying it is in need first from our individual assessment. That's an important point, because even if a research paper or study said something is effective, you should not be basing your treatment on what someone else tells you. You have to check if it's actually going on in the person right in front of you and your patient. If there is evidence of that in your patient and then you follow those principles and treat, it'll be okay, it'll be effective. But if there isn't any evidence of what's that going on in the tissues, if you treat based on the external evidence, you're actually negligent because you've ignored the tissues and what they're telling you. So you can't rely on evidence-based medicine, external studies to protect you. You still have to have evidence that your assessment and treatment is based on what the tissues are actually telling you. If you have, then you have evidence to back up your treatment plans. Okay, and it's not theoretical, it's practical as well. It's not just guessing, it's actually knowing. So we treat what is actually present and in need. This is the primary evidence. At least this is what our philosophy teaches us, and so does the body if we only listen to it. Yet medicine, although good with emergency and acute injury care, in my opinion, has few answers to the chronic healthcare crisis. Okay, so you've got to think of what different therapies are good for. Acute emergency and acute care, we definitely need medicine. Okay, they deal with the immediate issue, and that's important. But I'm sort of thinking more in terms of chronic healthcare crisis. Why is that going up? Because emergency and acute care can get people to coping, but is it actually helping people to heal? And if not, what do we need to do to help people truly heal? And I think that comes from the holistic assessment and the context of the whole picture. The more we understand what's really going on, the more we can educate our patients to what's going on, then they can take the necessary life or lifestyle steps or changes in their life to improve their health and not continually bottle themselves up or bog themselves down with more and more issues, okay, layering on top of one another. In a sense, to the chronic healthcare crisis, I believe that we, any holistic therapist, and especially us as osteopaths, we do have some answers, at least in potential, if only we did what we were meant to do. And so it's like we're doubting ourselves in a way, and we're saying, we believe that you know better, so let us become like you, i.e. like medicine or another profession or evidence-based profession. Let us become like you so we can feel like we fit in with your medical model. And yet, both professions, osteopathy and medicine and any other profession, slide deeper into ignorance about the very things they need to do to make both more complementary, holistic and effective. I think you can apply this to any field. And then the chronic health issue, the chronic healthcare crisis continues to rise. To many people, speculating intellectually about an issue with no real understanding and meanwhile completely ignoring those who do know because the answer is often so simple, it is completely taken for granted and missed, i.e. it's not complex enough to appeal to minds trapped in a reductionist and symptomatic model of thinking. The effect of us losing our identity and treating in the musculoskeletal system. And if you think about that statement, if you look at a lot of the definitions of what we do as practitioners, we're musculoskeletal therapists. No, we're not. This statement in itself is reducing the whole person to the whole musculoskeletal system or a part of it thereof. So it's in a reductionist biomedical way, from a general practitioner's viewpoint perhaps. Let me say that again. The effect of us losing identity and treating the musculoskeletal system in a reductionist biomedical way, from a GP's perspective perhaps, Maybe that by doing the same thing as they are in a different way, we're merely competing with them, and thus they may probably go on believing us inferior anyway. This is because no matter how hard we try to cram more facts into our education, we'll never have a more extensive knowledge base or training as they do in their eyes, which is actually probably technically correct. Their medical knowledge and training is very, very deep. Okay, it's very thorough. I would assume at least. Our egos thus compete and conflict, and they may not pay us any respect. We're competitively alternative and not complementary. See, if you think of the words alternative versus complementary, it says a lot. Complementary means you're pooling your resources. You're looking at the same patient, perhaps in different ways, and you're sort of complementing your skills to enhance the health and well-being of that client. Alternative is sort of like almost competing. You're doing the same thing but a different way, and then arguing about who's better. Which is ridiculous. It's like that analogy of people are blindfolded and they're given a different part of an elephant to put their hands on, and one's got their hand on the trunk and one on the leg and one on the tail, and they're all arguing about what it is they're feeling, but it's the same elephant. This applies here. Okay. So how do we respond to all this? We say, oh, we don't know enough. We're insecure. We don't know enough. What do? Let's cram more knowledge about pain pathways, symptoms, and conditions and medical tests into our education. And this will solve the problem and prove to the medical profession that we're competent and useful. Okay, that's just the thinking, right? But it doesn't work on its own, let me add, because the issue is not about one of knowledge or knowledge of conditions. It's about application of this knowledge to the tissues in need. This requires that we first find the tissues in need and then use our educational knowledge to explain the relationships between what else is happening in that person and the tissues causing symptoms, and thus describe the whole pattern cause to effect. It's also more about how to use our mind and senses to perceive information from our assessment processes. In short, to train ourselves to be an instrument to be able to read the body more effectively. This is about us acquiring internal integrated knowledge, or you might call it wisdom, not external knowledge. Intellectual knowledge without any practical understanding of where or how to apply it, which actually requires that primary tissue evidence, can actually result in a theoretical overload, which results in feelings of being overwhelmed, not being able to cope with the overload, which leads to more stress, conflict, anxiety, and eventual breakdown. As an example, I once was involved in a conversation. I think it was at a general meeting. One of the heads of uni there was talking, and I mentioned, I was talking about this issue of confusion, and they thought it was being solved by the introduction of more detailed knowledge and training. Because I was bringing up that I came across a student who had just graduated recently, and she knew what she wanted to do. She knew she had to try and find what's really going on treat, but she had a difficult client and she was completely overwhelmed. She did all this knowledge and all this training, but didn't know how to apply it to get any meaningful effects. In other words, the symptomatic approach and the condition approach was not working, and she was then left totally confused. Okay, but in this conversation, this other practitioner was talking about how that was being solved by the introduction of more detailed knowledge and training. So that wasn't really happening as much anymore. But it does. It happens every year. It's still happening. Okay? Because you can get this sort of illusion that if you put more knowledge and more training and more medical testing in, that it's got to solve the problem, right? But it isn't about knowledge. That's already adequate. Again, that'll continue to improve. But unless you're making use of that knowledge in a practical way, unless you know where and how to apply it, which requires you to know what's actually happening in the body, that knowledge is more or less meaningless. Okay? However, right, in the real world, although this increasing the knowledge was helping to produce more knowledgeable practitioners, the new graduates, despite knowing everything, still continued to have no idea what to actually do, especially with patients with chronic health issues which didn't practically fit anything they were theoretically taught. The result of this is a lack of confidence in one's ability to understand and help clients heal and become whole again. Heal is really a process of becoming whole again, coming back to what you once were, the natural healthy blueprint. So in other words, Learning how to read and trust the tissue responses to our assessments is a very different sort of knowledge, and thus confidence in the practitioner's ability to know what's actually going on is often lacking. Okay, you get really confident as you start to trust the tissues because the tissues tell you what to do and what's safe. It sort of cuts through all the confusion because it gives context and meaning to everything. Therefore, you end up treating based on what you know is actually happening and not having to guess. As a result of not developing confidence in the guidance of the tissues, students will then often fall back on their educational framework, but this is mostly theoretical and symptomatic, and although it offers information and suggestions and makes sense intellectually, how can we know for sure this knowledge is applicable, that it'll actually work practically, or if it's actually even needed in any individual case? The result is we often make an educated guess about what is happening, i.e. we think it's this differential diagnosis, and then we treat according to a symptomatic diagnosis. And if that doesn't work, we pick a different one. We hit another symptomatic diagnosis until we hit the mark, so to speak, or the patient may feel better temporarily at least, but are their actual tissues healthier or not? Which is a more reliable indicator of underlying progress than symptoms. If you think about it, how do you know you've made a good effect? You'll get improvement in the symmetry, the texture, and the quality of motion in the whole system. The whole body's got an increased percentage of health and a lower percentage of disease. That's how you know someone's getting better, even if they don't feel it on the surface. Okay, that's how you know someone's in a healing crisis, or whether they're getting worse. So the tissue health is a much more reliable indicator than pain or symptoms, especially in the long term. Where is the osteopathic diagnosis of the whole pattern of dysfunction linking what else with the tissues causing symptoms, and thus providing the evidence and the rationale for us to know exactly what we can do, which is safe, and therefore can actually make a difference? It's simply not there, generally speaking, in my observation, because when it comes to the crunch, how many of us or how many practitioners are really trusting the tissues over the external knowledge to tell us the whole story? The external knowledge is useful for explaining it once you've found it. That is one of the benefits of the modern education. So you definitely need to have all of that, there's no doubt. But once you figure out what's going on, you use your external knowledge to help explain, put it into a language we can all relate to explain that whole pattern of dysfunction. So how can we do this accurately and research these underlying problem patterns if the emphasis is on the tissues and tissue conditions causing symptoms? Well, if it's not being educated or done appropriately by those who understand it, then how can it be researched? This begs the question, is the research out there really osteopathic based upon real findings, or is it actual educated guesswork? Is it simply picking a technique out and trying it, say, let's try a technique to help on the neck to help with headaches, and then hope for the best? Well, if we listen to the tissues, they might, as a theoretical example, show a pattern starting down at the pelvis and having effects on the other end of the body. More results would occur in research if we picked this up from an assessment and treated it, rather than just treating every patient's neck. And yet we wonder why the studies show not much results from manipulating the neck to get long-term relief for headaches. I've actually looked into that one. I did some research on headaches and manual therapies for treating the neck for headaches, and that's exactly what it showed, very little change. Why? Because the neck, for one, may not even be the primary tissue causing symptoms. And secondarily, even if it was, it itself may have been set up by the underlying problem patterns lower down in the body, and thus itself is a secondary effect or a secondary problem, rather than a true primary cause. Practitioners who trust the body will often remark that the tissues causing symptoms rarely need any treatment unless there's an actual primary dysfunction present in that area. This can be easily demonstrated with a simple group postural exercise, which I demonstrate in the videos I made on my research. Okay, I think I've got an example in the last one of those. And yet it's rarely done in my professional clinical and teaching experience because of the distraction by secondary issues and effects. This is easy to remedy if we teach students to accurately learn how to read the tissues of the body. There's no downside to learning how to read the tissues of the body. It improves practitioner confidence. It improves the context of what's happening in the whole. It helps you to form safe and more manageable treatment processes to restore healthy balance and function to the body. So you don't actually, you use everything you've already learned. You just tie it all together. It's simple as that. Okay. So teach students to read accurately the tissues of the body till they get really good at it. And then you can start doing research around treating primary problems and their effects, as opposed to just treating effects to get long-term improvement. So getting back to our proving ourselves to the medical profession or world idea, if we're good at our own profession, other practitioners will more likely say to us, wow, I don't know what it is those osteopaths do exactly, but it works. They have a different approach to me, which will complement my work, so I'm happy to send my clients to them for supportive treatment, because you're complementing one another. You're not fighting against one another for clients. You're all working together for the benefit of that health of that person that's coming to see you all as part of their management team. So in this way, we actually earn respect, true respect, and retain our professional identity, and we can fit in with other professionals in a very healthy way. So the way it is now, it seems we're losing our identity, and although osteopathic practitioners potentially know a lot intellectually about anatomy, conditions, and medical investigations, etc., including regional and symptomatic treatment options, there are arguably fewer practitioners who really have the confidence in what they're doing in the context of the holistic side of things, treatment of the whole person, and knowing actually how to apply their knowledge to the tissues or primary evidence actually in need of attention to help restore health to the whole person. Biomedically, there is competence, you could say, but osteopathically or holistically, I'm not yet convinced this is actually the case, except in a few cases. So that gets me to the end of the discussion. As you can see, it's a lengthy discussion. It's taken us quite a while. But I have to spend time on this because the problem is so subtle and insidious that we have to really reason it through fully. And I know that takes effort. And I know it's a bit painful, but it needs to be done at least once. So now I'm going to get on to part 2, which is my evidence. This is anecdotal, my own research evidence, and life examples from my own experience and observation. In other words, and even looking at things like Facebook, LinkedIn posts, webinars, teaching courses, and so on. So I'm going to go through a few examples. And there's many I can share, and this is over 30 years. And I'm including some actual specific examples here to illustrate my point. So first is social media. If we look at comments on internet sites such as Facebook, LinkedIn, you'll often come across people asking for advice on ideas to help manage difficult, complicated, or chronic cases, and that's natural. One thing that always strikes me odd is that when we look at the information provided by those practitioners, it's usually symptomatic or describing a regional part with symptoms. So what is that? 1B, regional symptomatic, not holistic. 1A. Rarely are the more important findings of the whole person behind the scenes, 1A, explored and described. There's usually a very detailed and thorough description, often regional, of the history of the condition and the pain and symptoms, so that's fine. When examination findings are presented, they're usually only listing the results of biomedical tests or regional orthopedic or neurological testing procedures, but not necessarily osteopathic ones. In other words, it's more testing rather than the ART sort of feeling it and seeing it sort of concept. In some cases, regional examination findings are included from observation, palpation, or motion testing, but even these are often so rare to see used in any way other than to describe tissues causing symptoms, which is 1B focus, not the relationship setting them up, 1A. Why are only these findings presented if they weren't the emphasis in education nowadays? Okay, that's a question I'll ask. Practitioners then often ask for advice on options for treatment without actually providing any tissue evidence or findings about what is actually happening in the relationships with other areas of the whole person in the background. The very thing I would say they truly need to be able to answer their own question, I would suggest. Without this evidence, it's difficult to get a holistic feel for the patient in question and give any constructive advice. It's like an intellectual case study presentation where all the important examination findings for context are omitted, and we intellectualize our treatments based on a pure theoretical speculation. Based on what? Past or present educational background knowledge and research, not primary tissue 1A findings. for underlying issues that need to be recognized in order to render treatment more effective. The responses almost always involve very detailed technical and anatomical answers, always usually related to the conditions, the regional anatomy, and the tissues causing symptoms, again a 1B emphasis. And then advice is given on all the wide and varied treatment possibilities based on personal experience or the latest research perhaps to treat it. And I'm not saying these are not useful, they can be extremely useful in the right context and if these findings are actually present. But the point here is that responses rarely discuss the category of 1A in a diagram of evidence that I've presented in the evidence summary chart. I always ask the same things. Where are the primary ARTs? What's happening elsewhere setting the stage? I might give some clinical examples of anatomical relationship links to consider, which may guide the assessment process if not already done, such as neural links, sympathetic, parasympathetic sites, organ links, mechanical relationship links, psychological links, and so on. Yet, these comments rarely seem to make any impact, except perhaps on one or two people who do think about them and may say something, but that's rare. They are usually generally ignored and even rejected sometimes as it challenges people's reductionist mindset, I assume. Yet all the answers about condition or symptom or pain are acknowledged and repeatedly seem to get numerous likes, as do all the various treatment options addressing the regional areas. So that's my social media example. So that's one example. Second example, webinars. This is another interesting one because webinars are provided to help us become better practitioners, both theoretically and practically, and to keep us up to date about the latest research. It's assumed that because of the evidence-based research component, that it naturally will help us reach this goal. However, often because the research is about 1B, regional assessment and condition-focused, symptom-focused treatment, it's usually not that helpful to practitioners in the context of what is actually helping them to know what to do osteopathically, other than on a regional symptomatic level perhaps. If we based our treatment upon what the tissues actually tell us in many cases, the researched information is of limited help because it's rare in the context of the big picture that we actually need to do what is suggested symptomatically or even regionally speaking. It may be helpful when it's needed, of course, so don't get me wrong on that one. I always like the webinars and therefore technically must give them good ratings at the end of the webinar survey, but it does not tell us the full story and make clear what we're actually missing, i.e. the osteopathic part from such approaches. Perhaps if I describe what I get out of them in a checklist fashion, it will become more clear what I mean by this and why I feel the osteopathic part is missing. Note, this is in reference mainly to topics such as an osteopathic approach to patients with such and such condition, or in reference to research being conducted about the effects of osteopathic manipulative treatment on, OMT on. So, A, anatomy review, usually it's great, it's pretty good. Condition review, B, that's usually great too. C, regional symptomatic information and research, even treatment where appropriate, that's usually pretty good as well. So you get ticks on all those three boxes. D, osteopathic approach, question mark. This is rarely, if ever, discussed. And I'm not just saying this, I rarely ever see an osteopathic approach discussed. Sometimes it's discussed a little bit, but not very much. And probably part of that's because it's easier to discuss the tissues and the conditions and the research than it is to give us some sort of clear indication of what else is happening, because that's going to vary case to case. But I think it's omitted because people just often don't do it. So I use the webinars to refresh my biomedical knowledge, but it's rare I get anything out of them in terms of improving my osteopathic treatment because the tissues always know better. Rarely does an actual integrated osteopathic approach get a mention, except perhaps that it can help when done, but then other than the regional aspects, the actual osteopathic treatment approach itself is rarely holistically described. All the indications suggest that it's a biomedical approach or a regional technique or treatment approach disguised as true osteopathic approach to treating and managing a patient with a condition. Again, category 1B evidence rather than 1A. Note, if there is a limited or no holistic osteopathy in the talk, we shouldn't technically call it, just because we're osteopaths giving a talk, an osteopathic approach or research to, as this is actually misleading. Instead, we should say a review of regional assessment and treatment approaches to. or the effects of regionally applied osteopathic manipulative treatment to patients suffering such and such a condition, or one osteopath's clinical approach to. In this way, it provides more accurate information and not misleads viewers into thinking this is holistically applied osteopathy, and will not annoy the hell out of osteopaths who look more at the bigger picture because it's out of context. We'll then get more out of it because it's presented in a more balanced way as part of the picture and not the whole picture, i.e. we will learn the best bits of it without risk of limiting our holistic viewpoint. I'll continue on this, specific examples. Okay, first one, a recent webinar I watched at this time, and I wrote the article, ticked all the boxes mentioned above except the osteopathic one. It presented in a very well and I enjoyed it, except there was technically no osteopathic approach in it. Yet it was called an osteopathic approach to blah 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 blah. Another webinar, another example I watched a while ago now was about research being conducted investigating from memory the effects of OMT, osteopathic manipulative treatment, combined with exercise in a patient suffering pulmonary conditions, right? Chronic pulmonary conditions, I think it was. Now, the osteopathic treatment described was as manipulating the thoracic vertebra or something like that. I couldn't tell at the time if the researcher was referring to manipulating one specific vertebra or working on the whole area generally, or any of the potential vertebral ribs found to be dysfunctional within that region. Now, I think this research can potentially be very useful research. However, what was presented arguably sounded more like a regional treatment-based approach on the reasoning that the thoracic spine relates to the lungs anatomically, and so if we find and treat issues there, we'll see if it actually helps, which is fair enough, right? But although the reasoning is partly sound, regionally speaking, it seemed to not include consideration of the holistic individual elements, i.e. what else is going on in the whole person, for context about what is happening behind the scenes and how it relates to the presenting condition. It may technically be testing only a regional osteopathic approach, and that's only if the primary ARTs are indeed addressed in the region, but not necessarily a full holistic osteopathic treatment, because if it were, it would be taken into account individual findings in the whole person, which do play a role in interfering with recovery from a lung pathology, and which findings might relate to primary issues elsewhere in the whole person, setting the stage, so to speak. So treating everyone's thoracic spine in part or in full, especially without an awareness of whether the tissue findings there are primary or adaptive, takes little account of patient individuality and may simply be trying the same technique on the same part, or guesswork perhaps, rather than really knowing if it was actually in need or not, and hoping for the best with little understanding of why it might be needed and where it may be needed and how the body is responding to the application of the technique based on tissue feedback. But we can't evaluate this fully until we see the finished product, the finished research, and see what it has to say about what's actually done or not. But they're all really important questions to ask, okay? Because we can assume that this is a really good osteopathic treatment's been done to help these patients, but everything I just mentioned, and based with everything I've talked about, is that actually the case or not? And I'll go on further, okay? When I mentioned, imagine what would happen on the effects of OMT, osteopathic manipulative treatment, on a patient recovering from lung pathologies, if the primary relationship imbalances elsewhere were also dealt with, which are interfering with the self-healing mechanisms, the response I got was, oh, but we have to deal with the immediate problem, i.e. the symptomatic effect. So again, this sort of indicates to me primarily a focus on the condition or symptom model of practice, which again is fine in the right context. The significance of my statement seems to be missed, or at least its importance minimized. And why? Because I feel it's an emphasis on the tissue or condition causing the symptoms. Investigating the primary evidence for 1A has potentially little value because its importance may not really be understood or practiced. So how does a purely regional approach reinforce osteopathic principles in practice? It seems to, in a way, contradict them, in fact, because we all know that if we deal only with conditions and symptoms, often symptomatic effects, without dealing with underlying causes, primary problem patterns, then they'll only reoccur with little long-term health gain. How is this supporting the self-healing mechanisms other than on a local level or part, or demonstrate the effects of holistic osteopathic treatment in research? It's like mowing the lawn without pulling the weeds out, okay? That's the analogy. Dealing with the underlying causes naturally means the symptoms will disappear also in time, because as a person gets healthier, the body will tend to take care of itself, i.e. the load is off the symptomatic structures, thus enabling them to heal more efficiently or effectively. To what extent am I to trust such research as being fully osteopathic, and then use it as evidence to base my own practice upon, unless the holistic elements of the problem are also considered? The results of this research, when it is completed, will likely be meaningful only in the context of how a regional approach on its own can help, and if it gets some positive results, which I'm sure it will, how can we then differentiate between the benefits attributed to the exercise component, which may directly or indirectly address more of the whole person or more of the what else, compared with the osteopathic manipulative part, which may not necessarily incorporate the what else? Most research on regional treatments and techniques would, I suspect, show slight significance, or more in some cases, dependent on how much of the bigger picture is included in the study, because it's logical that a part of the picture will obviously include the regional anatomy involved. However, it's also logical, particularly with patients with chronic health issues, that there may be many other areas and relationship imbalances between the involved anatomical components elsewhere within the whole person, collectively contributing to the manifestation of the symptoms, either setting them up or otherwise interfering with their recovery. So the more of the what else behind the scenes we do identify and include into our treatment process, then logically the better would be the results of our treatment. Why is this the case? Because it accounts for a wider variety of potentially involved variables and their interrelationships than a regional symptomatic view does alone, and which only looks at one relationship, that between the condition or the tissues causing symptoms and the symptoms themselves. The conclusion here is that this holistic osteopathic approach for the primary issues setting up the whole problem pattern, cause to effect, is therefore the hypothesis which requires further testing in order for us to realize the potential of what we can do to support the patient's healing. We do it every day in our practices with good results. It just needs to be done in external research as well. Results of this, I would argue, would be far greater if osteopathic treatment to the underlying individualized problem patterns were addressed effectively. Because, in my view, few people, in my experience, seem to be paying attention to this fact, I'm making it blatantly obvious that the focus nowadays is more on 1B regional symptomatic evidence, not 1A holistic. Okay? Now, I realise that I may be construed here as being a bit harsh, but it's my point here to make evident that the true holistic osteopathy is almost unconsciously being lost due to this reductionist approach, all in the name of osteopathy. We say we're holistic, but are we holistic? Okay, as good as this or any other research may be from a biomedical condition or symptomatic viewpoint, it seems apparent that there is still a vital component missing to tell a fuller story about what it is we do and can do well, and this is related to the holistic assessment and treatment of 1A evidence. So as a consequence of all this, we can automatically assume, therefore, that any research, past or present, is holistically osteopathic rather than regionally or partially osteopathic, or even more limited to tissues causing symptoms, without even questioning it. Again, how do we know that the assessments in current or past research projects are performed, A, both generally for what else, and regionally for details of involved components, as well as performed with awareness of tissue response? Or B, whether assessment is regional or local only, or if assessment or treatment technique is applied routinely to the regional anatomy without paying attention to the tissue's responses, which would actually tell us whether they are needed or not in treatment. So refer to my teaching example below for a start discussion on this point. Are we meaningfully assessing patients' postures, or are we applying a try this and hoping for the best approach? These are all questions we should be exploring to determine if any research is truly holistically osteopathic, regionally osteopathic, purely theoretical, biomedical, or not osteopathic at all. This is no one's individual fault, and I mean no disrespect of the contribution of any research that may provide. Okay. It seems to be a natural consequence of the current educational system, and I'm only pointing out that there is still something as yet missing that I believe will further improve the results of such research. Even regionally implied, especially if something addresses key tissues in that region, it should still provide some supportive evidence that manual therapy treatments can make a difference. But from a holistic osteopathic point of view, there is still so much untapped potential for us to do even better future research. All we need to do is add back in with equal emphasis the holistic philosophical and assessment elements with knowing awareness. Example C. Now we come to some research examples. I read an article a few years ago by a researcher, I think in Italy it was, who had a closer look, and I had recently a closer look at it to make sure I've got my facts right and talking about it. Investigating the inter-rater reliability of sacral palpatory diagnostic tests among osteopathic students in their final year. So basically it investigated the TART concept, diagnostic principle. And out of the 4 criteria, guess what? Tenderness was the most reliable, what the patient feels. Okay. In the paper, the researcher mentioned other research where tenderness was similarly identified as being prominent. But if we take a closer look at the discussions therein, it's very clear that the diagnostic skills in the students in their final year, you could sort of argue, are less than 30% reliable for interreliability for ART, asymmetry, restriction in motion quality, and tissue texture change, and a little better for tenderness. So the question I sort of asked here made me think. I thought it was a good, worthwhile study to look at. If only 30% of reliability is present in final year students, then what does it mean about the competence, quality, and trustworthiness of practitioners in entering osteopathic practice? And what hope is there of conducting any useful research if we can't remedy this inability to assess the tissues effectively and thus clear any confusion? But what is tenderness? Tenderness is a symptom that the patient feels. It's not what we feel. Thus, the emphasis here goes from trusting our findings to distraction on what someone else tells us, i.e. effects. There's a subtle shift there if you pay attention. And what do symptoms relate to? Well, the answer is tissues causing symptoms, which relates again to a regional approach to assessment and treatment, which is the 1B. So I'm sort of just dissecting all this stuff for purposes of analysis, something which I think we all should do. Now, we could argue from this that, you could argue from this study that ART in TART is only slightly reliable in the research, and therefore we shouldn't give it much importance. But can we? It's still a slight step forward, is it not? Can we throw out a useful principle simply because the research demonstrated limited viability as yet? This is an arrogant assumption, and one which we assume we know better, that we must be competent, so the only logical conclusion is that the principle of ART, or even TART as it has become, is not. Is it not more reasonable to conclude that given problems are present in the human body, affecting a person's health, then to some extent these problems will show dysfunction, in other words, altered quality of movement, altered textural feel, and symmetry in the sense that they are out of sync with areas of health? ART must therefore always be present in primary contributing areas, and if so, any ability to find them is our issue and has got nothing to do with the usefulness of the principle of ART itself. Thus, our lack of ability to measure ART simply demonstrates we're not there yet. It's our understanding of our very own philosophy that is still, generally speaking, very limited. A.T. Still, the founder of osteopathy, obviously had it worked out to some degree because he treated patients with any sort of condition and problem, holistically and effectively, I might add. From observing real-life tissue evidence, he developed the philosophy and principles and had them practically worked out in action, and so presented them to us in a very simple form to help guide our own practice. They are the secrets to success if we can manage eventually to understand them. We as individuals in the osteopathic profession are still struggling to understand and practice these principles as yet. However, I can assure you that any practitioner who does can more successfully assess and treat patients with a wider variety of issues better. Why? Because the philosophy is lived and not merely taught and thought of as a vague theoretical idealistic concept. I actually wrote to that researcher and he was happy to discuss ideas about ART and TART, which I cover in another discussion, and I've made a little link to an article I wrote on this for more in detailed reasoning on it. I'll put the link at the end, so I won't go into it in depth here. But in this article, I discuss logically and rationally that in any area of symptoms, especially A and R, in terms of range restriction, not necessarily quality, and T and tenderness must all be present to some degree. So it's not surprising that tenderness is most reliable. But in context with the big picture, at least the important one, especially in a symptomatic area, ART may not, however, be present to any significant degree because it's the effect. Symptomatic or regional tissues are only explored. ART, however, may not be present to any significant degree because the effect, the symptomatic or regional tissues explored, could all be adaptive and thus may change slightly with slight shifts in posture. So that's an interesting one. If something is a primary problem, it'll still be there in every posture. If it's an adaptive finding, when you assess from standing to sitting to lying or change the posture, the adaptive findings will also change, and that is a clue whether you're in the right track or not. I pointed out that ART in context of 1A above evidence was what we used to identify primary areas and tissues in the whole person, or what else, which may not be anywhere near the symptomatic area at all. In a holistic diagnostic sense, we don't start with an area to test reliability of ART or TART, because how do we even know that we're on the primary area or an adaptive area? We actually use ART to find, in the first place, the correct treatable areas to begin with, and that this is a more consistent and set-in problem, so to speak. If we found this area first and then tested reliability, because it's an obvious problem and not just an adaptive one, a subtle adaptation, then I'm sure reliability would actually improve. This holistic context would also help us understand why secondary adaptive and symptomatic findings change as they often do, and are thus why they are so inconsistent. The researcher wasn't fully convinced that the whole ART concept was a useful diagnostic tool, I don't think, that it was a bit of a speculative thing, and the results of the research seem to indicate this to some extent, but I would argue that it's 100% reliable to find the real problems in the body. Okay, so and you can prove that with a few little examples. I do one example, I think, in the little videos I made on the multidimensional model. A very simple one you can do with a group of people. You basically, create a problem in the body that is fixed, and you adapt the body around it to see how the tissues, to get everything as balanced as possible. And I did this once with a group of 100 people. So I created a problem around the thoracolumbar area. I got them all to hold a posture in extension, side bending, rotation, as if it were fixed. And then I asked them, how many of you feel symptoms where we've created the problem? And only about 5 out of 100 felt symptoms in that area, and then the rest of them felt symptoms elsewhere, like neck and shoulders and knees and opposite side of the back. So I did that. You can do that a few different ways, but basically the result of that shows that in literally 2 minutes, you can demonstrate that if you just treated symptoms, you'd only get 5%, maybe a 5% significance results, because only in 5 cases out of 100 in that particular example had primary problems where the actual symptoms were, and the rest had primary problem. Primary problem was in the same spot for everyone, but symptoms were different for everyone because they all adapt differently to the same stress, and they've all got different past histories and past traumas in their body already accumulated that they have to adapt around in different ways. So that explains, you can do it in a 5-minute demonstration. You can prove this concept. And logically, and you can actually, in common sense, you could argue all three must be present. So let me ask you this, though. If we aren't feeling for texture, symmetry, and motion quality restriction, then it makes me wonder what we as practitioners are even making our diagnostic assumptions on. Are we making our assumptions on mere perception, mere belief, or is it based perhaps on a pure historical or case history reasoning alone? It seems we can't be truly acknowledging what we are feeling or observing to any reproducibly helpful level. Otherwise, important areas of ART would show up quite clearly from our assessment. Or are we perhaps as practitioners feeling findings almost unconsciously perhaps and intuitively about what is happening behind the scenes, and we may even treat these areas or this what else to some extent in some way, but can't perhaps explain it in any adequate way which describes the relationship between what else is going on and the tissues causing symptoms. This was one of the themes that became evident from my own research. Many practitioners may actually be basing their treatment on these feelings, but are not even realizing they are actually, to make it conscious, feeling for signs of ART. Then, being distracted by an overemphasis on symptoms, perhaps mostly pain, they place their attention instead on effects without really appreciating the causes they have unconsciously felt but not fully consciously acknowledged. The researcher in this paper on TART also suggested in his review of the literature that there was little agreement on how many parameters of TART are even needed to diagnose somatic dysfunction, some indicating that at least 2 were needed. Yet I would argue, and can even prove as a fact, both theoretically and practically, that all 3 of ART must in fact be present. If only 1 or 2 are present, then it would be more likely indicate an adaptive secondary problem, even if it's symptomatic. But even to realize this means practitioners need both to understand the true value of ART to identify key issues and be able to actually find what is actually there to begin with. To even ask questions about the reliability of ART in itself means that practitioners do not really understand it, because if they did, there'd be no need to question its importance. I have found ART concept to be 100% reliable if we use it properly. I'm going to use that keyword, if we use it properly. Because the tissues will always have a primary dysfunction pattern present behind the scenes, setting up the tissues causing symptoms. But to be able to find this requires itself 2 things. The first one is that there's a holistic screening procedure that is followed, okay? You have to be able to do it first. The second is that you actually also have to be able to develop ourselves as instruments to pick up information from this assessment process, to see things as they actually are without getting ourselves in the way, so to speak, i.e. that assessment for 1A is actually being done and we're getting meaningful findings from it. I'll give illustrations about this and how it's not generally being done from my teaching experience, which follows next, in various manual therapies courses in the next example. But how can this be done at all if the emphasis is on 1B, or even worse, based on history or intellectual knowledge about conditions alone? Note, this variable of assessing from neutral and seeing things as they actually are in my teaching experience is of key value in obtaining consistent findings between different practitioners. If we can't all feel the tissues as they actually are from a neutral, unbiased perspective, then what often happens is a practitioner will often get their own perceptions, beliefs, biases, and expectations in the way and read off or perceive a combination of their own issues along with the patient's issues, and thus accounting for differences in findings. This can be demonstrated practically, but I'm not aware of any tool in modern research that's able to measure this or account for this variable. The researcher in this study does mention other useful reasons why reliability may be limited, for example, adaptability of the tissues over time, not including relationships with other areas of the whole picture, which is the one I just emphasized, needing a wider variety of diagnostic tools for perspective, all of which are worth considering, and that more investigation is needed to improve this reliability. So that is a really valid point, that last sentence I read out. He's even mentioned not including relationships with other areas of the whole picture. So even in his own statement, he's indicating the solution without really necessarily making the link between ART and TART and how they're useful diagnostically. However, all these things considered, it begs one important question. How can we improve student and practitioner training to accurately and reliably read the tissues of the body more effectively, to thereby improve confidence in ability to assess the human body for clues to primary and secondary dysfunction? How can we improve understanding of the relationships behind the scenes, setting up the symptom picture or otherwise slowing recovery by interfering with the self-healing mechanisms? This is obviously needed to raise reliability from maybe 30% to a much more acceptable level. So I'll get into this later, but for now we're gathering evidence that this fact is in fact needed. Example D, teaching experience. Now, from time spent in manual therapies and teaching manual therapies over 20 years or more, this overfocus on 1B has also been abundantly clear. For example, past clinical supervision of 50 students at one of the osteopathic colleges demonstrated that very few students really had any idea what was actually going on holistically in their patients. I'm sorry to say. No one wants to hear it, but that's what I noticed. For one, they had limited time, only about half an hour, which in my opinion is not enough time to learn how to feel and trust the tissues. That's what they should be doing, spending time to learn to feel and trust the tissues, let alone make sense of what any of the findings uncovered actually mean. This means that students were rushed, and what happens when we're rushed, we skip steps, and unless our assessment processes are very competent and well ingrained, and we do understand what we're doing, we consequently miss all the important information from our general assessment, when performed at all. That's if the general assessment is performed at all. And the focus instead on what we perceive is more important, i.e. regional symptomatic findings. This is exactly what most of the students did. The history taking was extremely good, but then again, that wasn't unexpected because the history forms themselves gave them consistent practice at a very thorough history. This very setup of the forms and the history checklist included a very thorough general history, a past history, a regional history, and a systems history, which is actually gathering information about the whole person, right, from their past and the whole history. That's really valuable. Yet their actual postural assessments included, at best, only a regional screen. Some of them poked about what they guessed was going on without really paying much attention to what their observation, motion testing, and palpation findings actually revealed. They performed assessments, but in terms of acknowledging clues or responses from them, I'm not so sure whether they actually found any or were just making it up to suit their pre-made interpretations. They didn't really acknowledge most of what was actually going on in the whole person elsewhere contributing. Because they didn't actually do this well, many of them didn't fill out their postural diagrams on their history forms at all usually, or correctly, other than perhaps sketching where the pain was, perhaps. And then they often guessed at what the most likely diagnosis was, and then they had to add in contributing factors because they had to do that. They then made them up often as contributing factors just to fill the forms in without actually confirming if these contributing factors, if related to the posture, for example, were actually present from their actual assessment. So a lot of things are done almost like routinely and making it up a bit without really knowing for sure. Okay, so something's a little bit missing in the grounding this stuff in to make sure it's actually there. In other words, they decided what they thought was going on, and then they proceeded to treat based upon this assumption. They then wondered, in cases where the causes were not in symptomatic area, why there was very little change in treatment. So it would work okay as long as the primary problems were in the symptomatic area, but otherwise it was a bit tricky. This could only happen to the extent that it did. I'm not saying it's not taught, but there's something missing, okay? Something is not getting through. It could only happen to this extent if the regional biomedical assessments were emphasized as important, but the general osteopathic assessments were not. As a consequence, they performed routinely one with more awareness and not the other. When I tried to open them up to the bigger picture by pointing out other findings in the whole person, they generally speaking, except in a few cases, didn't really want to know. I assume this was perhaps because opening them up to the big picture would mean they had everything they actually were doing or might be doing might be based on false or limited premise, i.e. effects only. And they would therefore have to change their approach to accommodate a whole new paradigm of learning, and to realize just how little they really knew in terms of integrated internal understanding. They essentially, I felt, just wanted to go on believing they were on the right track, get through the course and get out into the real world, and perhaps sort it all out later, if ever, because if something's not really in a person's awareness via their good education, then it's not really even considered being out of mind, out of sight, so to speak, later on. So often never actually gets done. But this rarely later happens because if an assessment or any principle or truth is already underemphasized, forgotten or missed altogether as a student, and it's likely to remain so as a practitioner unless they later go to a course that actually opens them up to it again with more awareness of its importance, or they have a lot of interest in searching for the truth. There's always a danger that if not exposed to the whole truth, such as a holistic osteopathy, as a student, that the part of the truth that is known, which is often a reductionist version of osteopathy or holism, can be mistaken as the whole truth, i.e. we can think we know it all and become close to anything else because it's not even occurred to us that there's more of the big picture out there than what we're considering. These students are our future educators and researchers, and if they don't understand it, what hope have they got to teach it and research it correctly, other than a limited perception of it? A limited version then gets taught to those coming after, and so a watered down more and more version till more limited interpretations occurs until very little of the original truth remains at all. Some of the students even told me that one clinical supervisor actually told them off when they tried to explore the whole person and to stick instead to the regional local problem. This verifies a regional symptomatic dominance and actually impedes student learning, not enhances it. It's even gotten to the point where a focus on evidence-based medicine's become so distracting that I've heard some practitioners make some statements like, our osteopathic principles are outdated and no longer useful because there's no secondary external researched evidence about them, and therefore that they're no longer useful. This shows a complete lack of understanding of their value. It completely ignores the fact there's also no evidence proving that they are not of value. It also ignores the fact that there are plenty of primary evidence in everyday clinical practice findings if we could only bother to learn how to listen to the body and pay attention to them. Therefore, the only logical scientific conclusion we can make is that those making such statements obviously have no confidence in their ability to listen to and trust the tissues to tell them what's actually going on, i.e. they are insecure and so need some other form of verification to convince them that they're doing something useful, and that verification is the external research. This, in my opinion, is an incorrect personal use of research, i.e. to defend an ignorant position. Okay? So we can use research wisely, or we can use it to expand, or we can use it to limit. We can deny, obscure, ignore, or choose not to believe in a truth, but we can't change a truth. It's the same in any time frame or any place. Research will never disprove truths because they are, in fact, facts. It can only reveal more understanding of these truths as we individually evolve and use them wisely and research wisely. It can, to various degrees, research, if done well, demonstrate if people are using it effectively or not effectively, as in an early example I mentioned. People then get defensive when their limited understanding of something's challenged because it means the eradication of personal misperceptions, thus creating inner transformation, change, and growth. Yet embracing a larger perspective can, in the end, only enhance and not limit one's ability, understanding, and practice, if based upon a truth, as are our philosophy and principles. This is the same with true osteopathy or true holistic therapy in any field. That's why I'm taking the time to present this information. Why was the general assessment skipped in the educational area? I can suggest a few reasons. 1. It may have been rushed through in education, I talked about, but not practically implemented to any deep level of understanding, possibly due to the workload, the need to get through all the regional elements, and thus regional biomedical assessments were emphasized and practiced and examined a lot more, but the general not as much. Or 2, the value or importance of a general holistic assessment may not have been grasped or understood even by the teachers, because it may not have been developed in them in their own education either, a fact which emerged in my own research and life experience. For example, the true value of ART, how to use it, how to apply it, and why, and how it relates in an integrated way with the tissues causing symptoms, was not given proper importance, thus resulting in rushing through general assessment to get to the good stuff and to get our hands on the painful site to see what is happening. I mean, I even did that myself, made that mistake. Okay? It took me a while to backtrack and to go back to the principles and philosophy and then rebuild an understanding. It took me ages to get to that point where it all started to fall together. So this is an all too common phenomenon as a student, and as I said, I even did this myself, to rush into what we think is important and to miss everything that is actually important. But this can be easily remedied. One participant in my study indicated the second point to me. Okay, he said it was taught, but he never really understood why, and thus its importance was not apparent. He said he knows that other areas of the whole picture are relevant and that he could find them, but he couldn't explain exactly how it all worked and linked in with the symptomatic areas. He said osteopathy works, but he couldn't explain why. Now, this can be done. It just needs to actually be done in a balanced perspective with the compartmentalized biomedical elements. Okay, another example. I've also noticed this omission of the importance of a holistic screening process in all of my many years of education of manual therapists, remedial therapists, and so on. And I've noticed that even when the holistic principles are intellectually grasped, so the problem's a little deeper than even what I'm saying, even when it's holistically grasped intellectually, it's often not practically integrated and understood unless in clinic on a real patient. A proficient supervisor, i.e. one who can see the whole picture, takes a student by the hand and one, not only takes them through a full posture assessment, but also two, shows them how to observe, feel and sense all the actual findings from that assessment. And three, then integrate these findings into a full working holistic diagnosis which explains the relationship between what else is going on and the tissues or condition causing the symptoms. All of these steps and time are needed, therefore, to ground the theory into meaningful practical understanding once it's exposed in the first place. But here's the question: are we getting exposed enough in the first place? For example, there are many, many cases where students have performed a full assessment on a client and then went onto treatment and then have come out to me wondering why nothing's working and the patient's not responding as expected. This happened in the clinic, my clinical supervision over many, many years. This is especially in relation to the more complicated cases where the symptoms are perhaps in different areas from the originating causes, i.e. the primary ART is elsewhere. In every single case, I ask the students, have you observed, palpated, and motion tested the whole and the part and added in any relevant adjunctive tests? The answer was always yes. I then ask, what were your findings? The answer was that there usually were no prominent findings, thus the confusion, or very little findings, most of which were regional, in the symptomatic adaptive areas only, mind you. Of further interest was the fact that even regionally, because of the context of the whole was missing, the local details of tissue findings were also often missing, leaving the students with a vague sense that something was going on, but not having either the context or the detail to make any real sense of it. So what would I do? I would then go in with the students and go through everything again. And this is why students need more time, okay, getting back to my earlier point, to actually practice receiving clues, okay, developing themselves in instruments and receiving clues, meaningful clues. Except this time, I would help them to find and point out all the relevant areas of ART in the whole person, and then demonstrate how that linked to the area of symptoms. Once that context was grasped, it was nearly always clearly evident why the symptomatic tissues were not responding and what needed to be done to remedy it, because the students gained valuable information about what was setting up or maintaining the symptomatic area and thus interfering with its release, i.e. it was realized, not merely theoretical. The students had actually performed a whole assessment process, which can be performed quite quickly, but they had not acknowledged any of the meaningful responses or clues from the tissues. They often said, I didn't see or feel any of that. That was common all the time. Usually I had to reinforce this over several weeks. This is not something that usually comes straight away. It takes several weeks, can take a whole semester or even longer. Okay. I had to reinforce this over weeks with actual clients for it to sink in. But by the end of the semester, they were usually much more proficient at doing this for themselves and thus were able to speed up their assessments. They sped up their assessments because they got better at acknowledging things and they performed things quicker. So you sort of have to learn the assessment, practice getting clues from them, and then practice putting them into meaningful order and sense to form a working diagnosis. They then observed and felt clues faster to the point where they were performing and observing the response of the tissues simultaneously. Interestingly, they then got better results upon many of their patients than some previous practitioners with 2 or 3 times their training. especially with patients with complicated and chronic health issues. I saw some remedial therapists, for example, with 1 year of training, get better effects on their clients than osteopaths with 5 years of training, simply because they started getting good at seeing what was going on behind the scenes and using their massage or articulation to help the body come back into balanced relationship. Now that happens over and over and over. It's not how much you know, it's how you use what you know. Okay. So this cannot happen if the processes are taught only, but the ability to pick up valuable clues from those processes are not taught and reinforced by experienced teachers. Can you see now why, in the case of research, such as the example of testing the reliability of TART, it's not quite as simple as just testing out a principle or technique or a hypothesis. If it takes months or even years to ground theory into practice and achieve confidence and reliability in trusting the tissues, even with experienced guidance, how likely are we to achieve any valid reliability in students who have not had the time to fully develop it once the concept was even presented to begin with? The principles need, like anything else, to be applied in the correct way at the correct place at the correct time. They need to be practically understood, which, given all the examples I'm providing, is clearly not the case generally speaking. We have to know it, see it, and feel it to teach it. If it's out of mind, it's out of sight, and thus cannot be known, no matter how much we think it is. Participants in my study all said that the factors which made the most difference to the understanding and practice of osteopathy was not the biomedical education, which they did agree and express as needed, but was in fact their most limiting factor also, that's the biomedical, when kept compartmentalized. The thing that was important, rather, was going back to holistic principles and having good mentors or teachers who could teach the biomedical information in a holistic, integrated way. That was very important. It was not what was taught, but the way it was taught. Was it taught in a separative, compartmentalized fashion, or in an interrelated, holistic, integrated way, which demonstrated the relationships between areas and layers of the whole person, as well as relationships between primary and secondary or symptomatic areas? The emphasis is not on the objects or the parts, but the relationship between the parts, in other words. Thus, there's a difference between learning the bodies of knowledge and practically implementing and integrating this knowledge in clinical practice. This latter category is not about external knowledge at all, but it's about more internalized and integrated, and relates to the knowledge of ways to develop the practitioner's ability to use the mind and the senses to perceive and acknowledge what's actually present from any particular assessment process, whether it's general, regional, or local. Applied knowledge and understanding, i.e. wisdom, of all these relationships make us good at what we do. It's not knowledge, it's wisdom. Okay? Knowledge is part of the picture. Relationships and how to apply that knowledge is wisdom. Next example, private practice. Okay, a few examples in private practice. Another example might be of value here is one of relating to patients with chronic and complicated conditions who have previously seen many practitioners, many of whom may have been osteopaths, in my own clinical experience. In almost every case where the patient is not getting lasting results, the primary problem is usually somewhere else in areas of the body not considered and treated. When I asked them if these areas were assessed and treated, I often got a reply of no. Practitioners in general seem to be proficient with clients where the cause and effect are in similar areas, such as acute injury management, localized simple problems, but not necessarily when a primary area of ART is elsewhere, or where the other holistic elements are present in other anatomy, such as not purely musculoskeletal findings. Okay, this seems to imply that the general assessment process is often not carried out, or if it is, as with the student example, the findings from this process are not acknowledged and included into the treatment. So you can sort of see between theory and practice, there's quite a lot of stuff that needs to be considered. Yet participants in my study of holism in osteopathy all stated that whether they understood the relationships between other areas and the symptomatic ones or not, they always included what else into their treatment, or they would not get good results. Second example. Once I asked an osteopathic student who observed me in practice how they learn to assess a person, because it didn't seem familiar to me. It didn't seem apparent to me that she was familiar with seeing the bigger picture or in using the ART to identify what else was present. She told me that TART was taught, and in clinic they always have to reproduce the symptoms, which usually focuses on tenderness or the tender part, not the ART part. And they spend most of the time focused on this extent that it seems that nothing else gets looked at. Again, what's this? 1B, focus at best. I told her that while it was nice to find out what's causing symptoms, it was much more important to spend some time to find the underlying problem patterns in the whole person, setting up the symptoms or slowing their recovery, because this is what we actually can treat. See, if you think about it, do we treat something that's painful and symptomatic a lot of the time other than first aid? Usually it's contraindicated. Okay, so what do we treat? We treat ART. We treat what else is going on in that person interfering with recovery. So if you think about it logically, that has to be the conclusion you come to. It seemed pointless to focus on the things you likely don't even have to treat when the real tissues that you do actually need to treat at some point should get more of her attention. The context of the whole will usually make it clear why symptoms are there to begin with, and also provides solid evidence as to what we can actually do to treat more effectively. For example, if it's not safe to treat the effect, obviously, you can sort of see what can I safely treat that will support recovery and get things moving in the right direction. So that's sort of my private practice examples. There's many, many more, but that's enough to demonstrate what I'm getting at. F, the next example, some positive example. So we're going to talk about some positive things now that I have seen over the years. Okay. On a constructive note, I have seen examples of cases where the introduction of holistic assessment for primary evidence from the tissues did make a big difference. So first, in the osteopathic teaching clinic, there was one example of a student who wanted to see the big picture, yet was struggling and feeling overwhelmed with his confidence to work it out and make any sense of it. Now, because of the limited time frame they had with clients, we obviously couldn't go through everything thoroughly. So I just suggested to him to re-include the general screen, but just do it quickly, maybe 5 minutes, perhaps, spend 5 minutes. And do these things. This is the tips I gave him. I said, 1, first of all, I'd like you to observe all 4 positions of posture: front, back, side, and other side. Second, I want you to palpate with your palms the general impression. Palms are good for general impression. The 4 positions of posture, with respect to the areas you can safely touch and those you can't, of course. And third, motion test the whole person, standing, sitting, and then lying, okay, in all 3 postures. So basically observe, feel, and motion test the whole person in different postures. Because by doing that, he starts to notice differences in each posture. But as he did this, I asked him to encourage acknowledgement of what the tissues were trying to tell him, to try and focus on that element. I said, I want you to say out aloud to yourself what you observe and what you feel in terms of the symmetry, the texture, and the motion quality in each posture, and how these findings change in each posture, indicating perhaps adaptive tissues. So look, feel, move in each posture. Acknowledge what was happening in these tissues to see what was adaptive perhaps compared to primary more set-in changes. And I asked him to make just one comment to himself for each step. For example, generally make a comment to yourself generally about what else is happening in this person, and then regionally look at the area where the symptoms are and make a comment about what you notice in the area of symptoms in terms of symmetry, texture, and motion quality. Then I asked him to try and link the 2 afterwards to see if they were interrelated or related somehow. In this way, what I was doing was reinforcing his general assessment and his regional assessment process. And 2, I was reinforcing his ability to acknowledge clues from this process in terms of symmetry, texture, and motion. That's very simple. Now, by simply doing this over a whole semester, he developed his confidence ability to assess the whole person for meaningful clues, and thus improved his effectiveness in both assessment and treatment. Why? Because he re-expanded his viewpoint and started to notice more of what was actually there to begin with, i.e. provided context, in capitals, context. If we remember to ask the question, we will develop our ability to listen, observe, and feel for the answers. If we don't ask the question, we never notice anything to begin with, even if it's there. Out of mind, out of sight. All you've got to do is put it back in, put the processes back in, and then encourage acknowledgement of clues. That's it. Simple. Now, another example. Once in a remedial therapy clinic in an induction session, by going through the whole general assessment process with students whom I'd never met previously, and showing them how to acknowledge the clues from the process, they said they got more out of this 1 hour session than the whole 2 years in their previous education in terms of integrated learning. Even though they knew all the regional assessments, they had never learned how to integrate it properly in order to get clues from the whole person and link it to the symptoms. But even though they got it intellectually, I still had to spend time and deal with the same issue that I mentioned earlier in terms of actually putting it into practice in clinic. In other words, over several weeks of clinic, I had to ground this understanding home, so to speak, so that they actually integrated this knowledge and were able to produce and reproduce results consistently on their own. Okay, so once it's even introduced and understood, you've still got to spend time to build it in. That takes time and practice. Third example. I recently, or it was not recently now, a little while ago now, I was able to do a little workshop for students at one of the osteopathic colleges up in Queensland. And I taught them the content, assessment and treatment of the general holistic assessment in the evidence chart I mentioned earlier to the osteopathic students in Queensland. They found it extremely helpful to provide context about what we can do as osteopaths and to illustrate the importance of not only focusing on the tissues causing symptoms. Some of them were amazed about how treating the primary areas relieves the symptomatic areas without having to do anything to the symptomatic areas themselves. One of them even wrote a little testimonial for me. She sent me an email saying she tried it on a case of a lady with a lot of neck problems, and she treated the primary areas and got them relating to other areas. She didn't even touch the neck, and the patient walked out free of neck pain. So that sort of is real life evidence that this stuff works. So again, their emphasis that they mentioned was more on detailed learning in relation to 1B, the regional and symptomatic, and secondary external research, which is needed, but having the context of 1A reintroduced and re-emphasized into their learning for those who didn't already have it, what they needed, and gave them a chance to explore the practical implications of this that was extremely valuable. This is, I believe, the secret to resurrecting osteopathy in the osteopath. So, concluding remarks. I know this has been a long presentation, but I had to do it thoroughly. The beauty of this is you can stop and start it as you need. But concluding remarks. Okay. All of these examples imply that something is missing, or perhaps not missing, but rather not emphasized, and thus is fading from our consciousness, but not completely lost, I hope, in our education, research, and practice. Because we can't replace or repair what is missing if we're not even aware it is missing in the first place, I have gone to great lengths to demonstrate this lack. I hope that the earlier discussion and the evidence that I've presented and the examples I've given you have painted an adequate picture. And I'm not the only one who feels like this. I've spoken with other osteopaths who can see the bigger picture. They feel very much in the same boat. And some in my own research mentioned how new graduates also seem to be more and more focused on parts with symptoms than in people with problems. The solution, which can easily remedy all of the above-mentioned issues, is simply to bring Category 1A evidence back into equal balance with the regional, biomedical, and researched one, to lift its emphasis back into balance, okay? If nothing more is done than just adding back in more emphasis on the general assessment process for key areas of ART as a routine assessment for any patient presenting with an issue, and some acknowledgement is made about the responses from this assessment in terms of describing areas of ART, then would go a long way to rectifying the problem. As in the example of the students taking a good complete history, which I mentioned earlier, because the assessment process actually included it, if the general and the regional are both routine, we will start noticing more things both generally and regionally. It's logical. If we start noticing things, we can start including them in our treatment and think more clearly about the relationships between what else is present and our symptomatic findings. Then integrated understanding about what is happening behind the scenes and treatment effectiveness will develop naturally because we have a deeper understanding of context. If we as a profession don't truly know how to trust the tissues to tell us what to actually treat, then what does this mean in future education and research? Do we want less than 30% of practitioners understanding how to listen to tissues? Or do we want 80% or more? The current situation of over-reliance on external evidence is disheartening to some extent because only the tissues know, which is actually internal evidence. And if only we examined the whole person effectively, we would note what is actually going on and would then be able to help patients with more complicated issues better. The better we get at category 1A in the chart I presented, and in understanding the relationship to 1B, the better we can understand and treat these patients. It's the balance between the whole 1A and the part 1B will provide improved context for future education, research and practice. It will. It has to. We essentially need to teach students and practitioners how to truly and holistically listen to the tissues. Once practitioners are proficient at this, they can better utilize their background biomedical education and research to provide the building blocks and language they need to describe the relationships between what else and the tissues causing symptoms, thus painting a more complete picture of what is actually present in any individual case. The education process itself gives us the language we can use to describe. We learn the anatomy, we learn all the conditions, we learn all the tests. It gives us the language, but we still have to find it and relate it all to make sense of it, okay? We will teach what we learn and we learn what we teach. So if we don't know, we will teach others also to not know, thus adding to the collective confusion and inability to assess and treat effectively. So let me ask you this. Is osteopathy or any holistic therapy dying due to lack of emphasis on what's important or not? With this in mind, what do you think? Having discussed all of the above numerous life and clinical examples, I hope you can understand why I'm posing the question, is osteopathy dying a slow death due to overemphasis on a reductionist evidence-based, regional symptom condition-focused approach? I certainly don't want it to be, and I assume the profession and educational elements of osteopathy don't either. So what are we going to do about it? Osteopathy needs CPR lest its heart fail and we forget how to feel. I hope this has given you valuable food for thought. What you do with this is up to you, but I feel that if those who govern the profession are aware of the issues presented hopefully here in a logical, reasonable format, then something positive just might come of them. If those in education were likewise made aware of these issues, then something might just be able to be done about this also. The end result will be better education, better practice, and better future research. I have many useful resources myself on my own website, which will help you to look at, courses, articles, videos, YouTube clips to help with this, but they have little use if practitioners are not even aware of them to begin with. I've even got a holistic integrated assessment, treatment, and rehab course there that is designed to slot this element back in. So if you think it is missing and something you want to explore a bit more, have a look at my online holistic health education resources. There's some really nice things in that. There's an articulation course which is all about how to do this in terms of relationships with what else is happening in the body, not just traditional articulation. And there's a whole course on the assessment and treatment. It's the basic building blocks that are, I believe, needed to be plonked back in to the education system. It's like an extra subject integrating everything you already learned. If we integrate this subject in to what you already know, you have a more complete course. You have the knowledge, you have the processes, and you've got the integration and the ability to express and explain the relationship. So that should set you up for further exploration and growth. So you can take your assessment from part to regional to holistic to multidimensional, if you like, and you just go deeper and deeper because you're adding in more anatomy and getting a greater context. So I hope you've enjoyed that. I'll leave it there. Thank you, and I'll see you later. I'll leave some references there for you as well.